Hi, everybody. Welcome back. We're going to have a couple of presentations from the industry to give us some updates on their newest technologies and the toys that they made for us. And we'll kick off with Hemosonics, and it's going to be Dr. Melissa Berger again, going to explain how to clot smarter but not harder. Thank you so much.
Great, thank you. So for our presentation here, we're going to start out on a lovely Saturday afternoon when beep, 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 your beeper goes off. Great. It's an emergent type A dissection, just what you wanted to be doing on a lovely Saturday afternoon. So how are we going to manage this patient? So some of the key points I wanted to point out in this presentation is learning to anticipate the coagulopathy that we'll be developing using point of care testing to measure that, then precision use of factor concentrates and minimizing blood products. Aneurysms and aortic dissections develop baseline coagulopathy. So they're a little bit different category than just a routine cabbage or valve coming in. The aneurysm itself becomes a source of coagulopathy. So contact with collagen initiates the intrinsic clotting cascade and rapid deposition of platelets. For ruptured aneurysms, 50% had abnormally low platelet counts, and for unruptured, 28.2%. There's also an increase in fibrin deposition, meaning fibrinogen use, as well as increased fibrinolysis. This was a thing where they labeled platelets and then ran a scintigram over an aneurysm, and you can see the dark areas. This is an abdominal aneurysm with the iliacs branching up, but you can see the platelets accumulating right at the side of the aneurysm where it's forming and consuming those platelets and factors. An aortic dissection, similar thing, you end up with lower platelets, lower fibrinogen. It's often associated with a fibrinolytic state. In many patients, they'll get almost a chronic disseminated intravascular coagulation or DIC type condition. You'll see elevated D-dimers in these patients. The PT-INR is higher in TAAAs, and the PTT is similar to elective cases. They also have lower levels of antithrombin. So you'll often see all that intramural thrombus forming along the aorta and then clot within the lumens of the dissected area. So anticipate the coagulopathy. In our institution, we start out with a baseline point of care test with a Quantra. So this was our case here. So here we see our clotting time with heparinase. It's essentially normal. We haven't given heparin yet. The clotting time is also normal. The clotting time ratio, again, this is when you have your clotting time clotting time over your clotting time with heparinase to look if there's any heparin effect. We haven't given it yet, so this would be expected. But then we come down here. This is our clot strength. It's low, it's very low, and we haven't even made an incision yet. Here's our platelet contribution to clot strength. It's also very poor. And our fibrinogen contribution to clot strength, not good. So already the patients, he just barely made it onto the table, and we're already behind the 8 ball in this patient. They've already got an underlying coagulopathy just by virtue of having their dissection. What happens on bypass? So in this graph, it's showing you time 0, 1, 2, 3. So it's time 0 is coming into the room. Time 1 is just going on bypass. Time 2 is pre-protamine, and then time 3 is once they've reversed protamine and then getting on out of the room. And as you see, moving through the time points, you start out with on the, I think it's on the right side of your screen, platelets, and then fibrinogen on the other side. Start out low. The blue is elective cases for dissections, and then the red is the emergent TAAAs. And you can see that baseline, they already start out lower in platelets and fibrinogen. It drops dramatically when you hemodilute going on to bypass, but then that persists post-bypass. Similarly, here's looking at D-dimers, start out pretty high, and as you come off bypass, they do get corrected as you're correcting the coagulopathy. And the same thing when you go on bypass for the PT-INR, it goes way up. Similarly, the PTT and the antithrombin levels dip during bypass and never quite recover afterwards. It takes a while. So we know that cardiopulmonary bypass causes hemodilution. It itself is going to tear up platelets in the pump. You're going to get a decrease in factor 5, 7, 8, and 9 levels. You get decreased fibrinogen, and then by virtue of that, you'll get an increase in the D-dimers, which are the fibrinogen degradation products. Hypothermia impairs the function of von Willebrand factor. The hypothermia also causes a prolongation of prothrombin that's independent of coagulation factor levels because they can't function at lower temperatures. And these changes persist even after cessation of cardiopulmonary bypass. So how are we going to manage this patient? We've anticipated, we know they're coming in with bad coagulopathy. We get our baseline point of care testing and we see they're starting off bad. How can we use factor concentrates more precisely and do early aggressive correction? And how can we minimize blood products? So here's the old way, typical scenario. Protamine in. He's really oozy. Can you guys give something? We're starting some platelets. You ordered the 2 platelets and the 2 cryo before we came off bypass, right, nurse? Yes, sir. Hey, look, we need those platelets in faster. It's really oozing up here. I'm working on it. So let's see if the lab results are back yet. And it's a line. Hey, do you think that line looks more like a brandy sniffer, a champagne flute? Why is this lab taking so long? So then you pull out your handy diagram and you try to remember if it was the heptim minus the fibtim and the atim, take the square root, divide by. Can you get your nose out of that book? I need help up here. How much product have you guys given? We are at 3 platelets, 2 cryos. The 3rd cryo is running. Can you not give something better? You want some PCC? No, I prefer factor 7. You know this. Look, I'll see if the pharmacy will, okay. 1 hour later. He's still oozing. You sure you don't want some PCC? Yeah, sure, whatever. I'm never going to be able to close this chest. So typical scenario, you start shoveling in some product. In this particular case, they gave 3 FFPs, 5 cryos, 5 platelets. Because the coagulopathy was taking forever to correct, they ended up giving 5 red blood cells, mountains of cell saver that they kept slurping up and giving back to the patient. And then finally, we bring out the big guns, the PCC and the factor 7. This, by the way, is an actual anesthesiologist. This was Matilda Crawford. She posed with a hammer to knock out her patients. She is a real woman. And at this point in the case, you may as well just throw in the kitchen sink because it's going nowhere fast and you don't know if you're ever getting out of the OR. So can we be more precise? So what is an alternative scenario? Our alternative scenario is, as you are sitting by your perfusion machine, you reach over and you grab your little Quantra cartridge. You rip it open, you take out your cartridge, you pop the tube in, you stick it in the machine, and 5 minutes later, you have your results. Let's see what we have here. I should say 10 minutes. It takes about 10 to 15 minutes to get results. So we're still on, we're rewarming during this period. So we're still on bypass, we're heparinized. Looking at our clotting time with heparinase, it's prolonged. There's no clot detected without using the heparinase, so we expect that our clotting time ratio cannot be calculated at this point because we're heparinized, and that's expected. And here's what's happened in the aftermath of bypass. So our clot strength is miserable, very low, way out of the green. Our platelets are not even computable because who knows if there's a platelet left floating in there. The fibrinogen clot strength is, there's not even a clot detected. So basically everything's going awry terribly. So how are we going to fix this? Well, rather than, put in the order in the computer, get the nurse to call the anesthesia tech to go to the blood bank, to have them thaw the blood for 30 minutes, and then someone needs to get the blood and transport it back to the OR, and you start hanging it, you can simply take out your factor concentrate, conveniently located at bedside. You put it together, put it in, swirl it up, take it, draw it up into your syringe, give to the patient. So what is the evidence for doing this, though? Are these little concentrates any better than giving all these blood products? So this is a very recent publication, comes out March 29th of 2025. This is the FAERS-2 trial, huge multi-center trial where they were looking at using prothrombin complex concentrate versus frozen plasma for coagulopathic bleeding and cardiac surgery. And this was the 4-factor concentrate, if you're wondering. So they started out with, it's an unblinded phase 3 non-inferiority trial. They had 420 cardiac surgery patients, and they randomized them to getting either the PCC or the FFP. They're 3 or 4 units based on weight. What did they find? So their primary endpoint was hemostatic efficiency. In the group that got the PCC, the hemostatic response failure was 17.6% lower, meaning better compared to FFP. And then when they looked at the secondary outcomes, the patients who got PCC had lower rates of surgical reopening for bleeding, lower rates of red blood cell transfusions, which makes sense if you correct the coagulopathy, lower rates of severe or massive bleeding, reduced transfusion of other blood products as well was lower. Then looking at the serious adverse events, probably the most important one people always want to know is, does this stuff cause thrombosis? It in fact does not. The rate of vascular thrombosis was lower in the group that got PCC. Overall, all serious adverse events were lower. And notably, acute kidney injury was much lower in the patients that got the PCC. So which led the editors to include this editorial that you're free to go read. Is it time to replace plasma with prothrombin complex concentrate in cardiac surgery? And I will tell you, when we started using the Quantra device at University of Florida, where I was, we dramatically reduced the amount of FFP we're giving. A lot of it just became not necessary. Similarly, what's the evidence for using fibrinogen concentrate rather than giving cryo? Well, interestingly, in Europe, they don't even bother with cryo because it's a blood product and they're worried about pathogens in it. They only use fibrinogen concentrate. So this was the FIBRS, which is a randomized clinical trial. They ended up taking a total of 735 patients, split them in half. Half of these patients got fibrinogen, and then the other half got cryo to correct coagulopathic bleeding after cardiac surgery. And the primary outcome they were looking at was blood components, where they were using red blood cells, platelets, or plasma administered in the post-bypass period. They found that the number of post-bypass transfusions in the fibrinogen group was approximately the same to the cryoprecipitate group. The number of thromboembolic events in the fibrinogen group was actually lower than in the cryo group. And so it was a non-inferiority study, and they were able to show that it's non-inferior to cryo in terms of efficacy, in terms of correcting bleeding rapidly, and in terms of safety. The big advantage this has, of course, is that it's not a blood product. So it's easily just take it off the shelf, mix it up, doesn't need to thaw. There's not all these pathogens and particles in the blood, that are in the concentrate, rather similar to in the blood, that are going to cause adverse events such as trolley. It's very low volume, so you're not going to end up with TACO, which is transfusion-related circulatory overload. And so when they're looking at the effect of the fibrinogen concentrate versus cryo on blood component transfusions, interestingly, particularly in elective surgery patients, it significantly reduced allogeneic blood transfusion and overall healthcare costs. So this is a little graph here showing, looking at their different subgroups, what favors fibrinogen concentrate and what favored cryoprecipitate. So again, just to reinforce, there's no difference in adverse events, duration of intubation, ICU stay, hospital death. The thromboembolic events were much lower in the fibrinogen group, 7% versus 9.6% in the cryo group. And interestingly, they started to do a little bit of a cost analysis. There was decreased cost in the fibrinogen concentrate group, this was a Canadian study primarily, which is $3,000 less in Canadian dollars per patient, which is pretty decent savings, especially if you multiply that over 500 or 600 cases per year. So the old school way was kind of guessing, using your clinical judgment, waiting on the lab test, calling the blood bank, thaw the products, transport to the OR, transfusing multiple units of blood until your bleeding stops. The new way is rapid data-driven correction of coagulopathy. You can get fast point-of-care results using the Quantra. It sits in your operating room. It's ready in about 12.5 to 15 minutes. Then you can use that data to very specifically select your factor concentrates off the shelf, mix the concentrate, and give immediately in the operating room. So back to our type A dissection. We came off bypass using the Quantra device data. We knew we were low in pretty much everything, platelets, fibrinogen, clotting factors. So we gave protamine, and then we gave 4 grams of fibrinogen concentrate. We gave 25 units per kilo of PCC, the 4-factor concentrate, and we gave 3 platelets. Unfortunately, there was not a platelet substitute yet. I'm sure they're working on it, but at least we have minimized our blood transfusion significantly. This was all we gave in this case. And then after we gave the things to correct coagulopathy, this was our Quantra device. So we're now seeing the clotting time with heparinase is pretty much normal range. The clotting time itself is within normal range, is like your ACT. When I look at the ratio, it's equal to 1. And this is, again, the clotting time over the clotting time with heparinase. If it's over 1.4, we know there's still heparin effect that would need additional protamine to reverse. Here's our clot strength, nice and strong. Our platelet contribution to clot strength is back within normal range, and our fibrinogen contribution to clot strength, again, back into normal range. And finally, you hear the magic words, all right, we can start closing the chest. Yes. So here comes the CMO. That's just great. How much is all this going to cost exactly? Well, they're definitely upfront costs. However, looking at our data that I did with University of Florida, with the Quantra device, we were able to reduce the number of transfusions given to the patient overall. And because we weren't guessing at what we needed to give, we weren't loading the OR up with coolers full of products that we're going to give until the bleeding stopped and then give back the rest. So we're able to reduce the number of blood products ordered but never transfused. This was looking at our academic one hospital. We had 4 cardiac ORs. We do about 600 cases a year there. This was the number of platelets, cryo, FFP, and red cells. We give a total of about 2,348 units per year. And this was the number that we were transfusing, or that we were, ordering, but not transfusing, essentially wasting them. They got sent back to the blood bank, or in the case of the cryo and stuff, probably ends up in the trash. So that's a massive amount of wasted units. 2,348 units in one hospital, average size academic place over a year, and only 4 ORs. When I said in my morning session that we in cardiac surgery use 25% of the blood, here you go. It's a lot of blood. So the amount, if you were to use just an average indirect cost of about 12,000 units, or $1,200 for 1 unit of blood, you end up with indirect costs of about 2.8 million. We were using it just the one place where I was. So if you actually reduced, when we looked at how much we reduced our platelet use, our FFP use, our red cell use, our cryo, these are all products that we were no longer ordering and then sending back. We calculated the cost estimation of 2.2 million per year we saved by introducing the Quantra device. So yeah, there's some upfront cost to purchasing the machine and the little cartridges and everything, but the amount of several $1,000s for that is pennies compared to 2.2 million that 4 operating rooms are blowing through on a yearly basis. So big money savings there. So in summary, aortic dissections and aneurysms cause coagulopathy. You want to anticipate that, anticipate the coagulopathy developing on bypass. You can use the Quantra point of care testing to get the fastest rapid data to guide precision use of factor concentrates. And it is the fastest device on the market. Your results are ready in around 10 minutes. Factor concentrates are now being shown to be non-inferior to blood products in terms of such as cryo or FFP in terms of just getting the coagulopathy rapidly corrected. And they have lower risk of thrombosis compared to blood products and better safety profiles compared to blood products. So don't be fooled by the higher upfront costs for the factor concentrates or point of care devices, because the early data is showing cost savings of factor concentrates despite higher unit cost. And then with rapid correction of coagulopathy, the Quantra has also demonstrated cost savings. That is it. Thank you.
Thank you so much, Melissa. That was another convincing imitation of the surgeon.
It's almost like I've been there.
Yeah. And yeah, great presentation on the cost savings using the device. I have a question about the temperature. So you mentioned that hypothermia will cause more coagulopathy. Do you take that into account? Like when your patient is, let's say we're at 35, we can't close, but we're off bypass, we cannot warm anymore. Would that skew the measurements if they are at 37 degrees? I don't know if they are at 37, but.
So the Quantra device itself is going to warm the blood a bit to get it up to a normal temperature to then measure coagulopathy. It's not going to measure coagulopathy related to temperature. For that, you can look on your monitor and see the temperature of your patient and be like, we better try to warm the patient. And that could be any combination of, using fluid warmers, if you use the bear hugger blankets, underbody warmers, all that type of thing. If you're still on bypass, obviously you want to warm them reasonably well. I'll usually wait till we get to about 35 degrees while we're still on bypass during rewarming to do the Quantra reading, just because that way I know we're getting close to coming off. And I personally will try to shoot for getting us a little bit over 36 degrees, so at least like 36 or 36.5, because I know that once we come off bypass, the temperature is going to fall back down a little bit, especially if you're giving some of the cooler blood products, even though they're going through the warmer, like giving back the stuff in the venous blood from your blinking on the term. The cell saver, but also just the venous reservoir, you're going to give that back. It's going to be slightly cooler. So, yeah.
I have a question.
Yes.
So on the readout of the Quantra, do those numbers give you direction as far as how much of a product? Like, is there a certain level for like 1 unit of cryo versus 2 units of cryo or more?
So the company itself does not have a specific algorithm that it gives you with the device. Several institutions have developed algorithms, including where I was at University of Florida, we developed one, and we based it off a lot of data looking at, the way we actually developed it was we took laboratory data, so they had a number of, like the measurement of fibrinogen, correlated that to other viscoelastic testing, and then correlated that to Quantra. So we know what number on the Quantra matches up to, say, a fibrinogen level of 100, for example, or a platelet count of 50, for example. I can tell you what number on the Quantra correlates to that amount. And that in most people, because they train knowing that they want their platelets over, we'll say 50 or 100, or the fibrinogen to be 200, they can then use that number to guide how much blood product they want to give, or how much fibrinogen concentrate they want to give. And if someone wants to bring me my purse from over there, I did ask our medical director. This is something he's calculated. This is Dr. Bruce Spies. So this is not published. This is his stuff. But I did ask him how he calculates the numbers. Grab it off my phone here. So this is not officially coming from the company, just to be very clear. This is what he has done by digging through the literature independently. So he takes the fibrinogen concentrate, or sorry, the fibrinogen contribution to clot strength of the FCS number from the Quantra. He multiplies that by 95, and that gives the circulating fibrinogen concentration in milligrams per deciliter. So if you want to know what the total body fibrinogen is, you would take the milligrams per deciliter and multiply that by the circulating volume of the patient. So for example, if the FCS is 1.05 and you multiply by 95, you get essentially 99.75, we'll call it 100 per deciliter of fibrinogen, or that'd be a gram per liter. So if the patient has like a circulating blood volume of 5 liters, you would then need have 5 grams. So then to get to 2.5 or 250 milligrams per deciliter of fibrinogen, you would need to give 7.5 grams of fibrinogen concentrate to get there, up to a level of 250 of fibrinogen as an example. So, so there are ways to calculate it. There's quite a bit of data correlating the Quantra numbers to laboratory-based values that you can use. So I think certainly in the future, different institutions are going to develop their own very precise algorithms to say how many units. We did that to a large degree at University of Florida. I'm happy to share that algorithm with anyone that would like to see what we did. Again, it's not coming directly from the company. They're going to give you the device and the data, do with it what you will. But there are institutions developing algorithms that can be used that very precisely tell you how much you would want to give.
Thank you. We also have a question from someone from the audience, from the online audience. Do you bag up your pump blood, or do you send it all to the cell saver?
I'm sorry, do we what?
Do you the residual pump blood? Do you put it in a bag and give it to the patient, or do you push it through the cell saver?
That's a very much a it depends question. So initially, as we come off and we still have the cannula in, we'll give from the reservoir until the heart looks full on the echo. And at that point, I'll kind of stop because I'm just trying to get volume back in the patient, get them euvolemic. If I can get it all in, great. If not, then that will get concentrated down through the cell saver. And then as the patient starts oozing and you're sucking that up, eventually all that gets to the cell saver, gets concentrated and given back to the patient. So one thing I will say that we started doing that was very helpful, it's kind of unrelated to Quantra, but in terms of blood salvage, is we started using more and more ANH or acute normovolemic hemodilution, autologous normovolemic hemodilution. So we would take blood, once we gave heparin, we would take the heparinized blood off through the venous cannula and put it into a bag, and the perfusionist keeps the bag hanging there by them. And that's good whole blood. It has all of the factors and platelets and everything. It never goes through the pump. It just comes directly off. And it's to get really the results from ANH that you want, you need to get at least 800 cc's or more off the patient. So rather than trying to do that while you're preparing to go on, pre-bypass, when the patient's kind of unstable, they're just getting the chest open, which is what you used to do. We would take it off just before we're about to go on bypass. So that way, if the pressure tanks, you just go on bypass, you're safe, right? So you can take off pretty large volumes. So we try to get well over 1 liter of ANH pulled off and then kind of crash, so to speak, but go on bypass as the pressure was dropping. And that for us worked a lot better than getting it off earlier into a heparinized bag or citrated bag, I should say, and then keeping it, on the shelf, on the rocker until we're ready to give it back. And then we give that back coming off bypass just before we give protamine. And that's nice, pure blood that's never been through the pump, unlike the stuff in the reservoir or the washed blood from the cell saver.
In regards to the factor concentrates that you were discussing, not real familiar with those. And I wanted to know, in the scenario of ECMO, is there any specific way to administer those? Like if we give platelets and cryo when we're on ECMO, we try to put it through a peripheral IV so that it goes to the patient before it sees our circuit. And, we're kind of careful about that administration to preserve the circuit. Is there any of those concerns with those products?
For the fibrinogen concentrate, the reps from Octapharma tell me that you're actually safe to give that on bypass or on ECMO, that there is not an increased risk of thrombosis. Now, there is a time you're supposed to get over like 15 to 20 minutes or something, depending on the dose that goes safely through. I think I'd probably give it through an IV rather than pushing it directly into your circuit. just so it gets diluted out as much as possible as it's circulating through the patient. I don't know if it's wrong to give it directly into the circuit, but I personally would do that. But it is safe to do that. For the 4-factor concentrate, I don't know the safety data as far as giving that when you're still on bypass, or if you would want to give it still on bypass. On ECMO, and also with like the LVADs, I have given it, usually I do a little bit lower dose. So rather than 25 units per kilo, I'll go down to 15 units per kilo. I'll give it still over the prescribed amount of time. So it's not necessarily slower than what would be prescribed, but I usually just cut back the dose some because I want to make sure I'm not going to cause thrombosis of, the VAD or the ECMO circuit or whatever. But I've never, now granted thrombosis is not a high % risk, but the times I've given it, I've never had an issue with it clotting, knock on wood, for whatever luck that indicates from my anecdotes. But you can give it. I would say you want to do it judiciously, and you obviously want to measure very accurately the need for clotting factors rather than just like giving it randomly because the patient's, cannula site keeps oozing or something. You want to make sure you've ruled out any surgical causes, and make sure that you've documented with lab testing or like the Quantra or point of care testing or something that there truly is a factor deficiency. And then if you're below that, you're safe to bump it up to a normal level. It should be safe to do that.
Thank you so much. And we have to move on to the next speaker.
Great. Thank you very much.
Thank you very much.